Bom dia, muito obrigado, Mauro, muito obrigado ao Biology Education, professor, por a invitação. É tudo o que eu vou falar em português. So my task today is to discuss in the next 20 minutes how to make more simple antiretroviral therapy. This is, you can see here my disclosures. So we have a long way behind us regarding treatment strategies. We started with monotherapy. We went after that in 1994-95 to dual therapy and then to triple therapy. Then we tried to do structured treatment interruption. It didn't work. Mega hard, it was a need for very advanced patients. And then we went to simplification, using different ways. Dual therapy, non-daily regimen, STRs, and long-acting and extended-release regimens. A way not to go is monotherapy. All the attempts to simplify treatment with monotherapy failed. So this is what the international guidelines tell us about reasons to consider switch during viral suppression. My talk will be limited to patients that are already suppressed virologically. There are appropriate reasons that you can read yourself, and there are inappropriate reasons. And I want to underscore the inappropriate reasons. This is just not to be on the fancy side of the story. The idea is to avoid to use the newest regimen. Just because a regimen is new wouldn't be the reason to do it. Or to reduce cost at the price of a toxicity or intolerance risk of your patients. And no switch can be done if you are sacrificing virological potency. You have to take in account the reasons that are listed here as appropriate. And if you read in the box, clinicians should always review possible adverse events or tolerability issues with current antiretroviral regimens. Just because viremia is suppressed, it should not be assumed that people living with HIV is well adapted and tolerating the current regimen. And this is particularly true for countries in which efavirenz is still the most common used drugs, as it happens in many countries in Latin America, probably not in Brazil, probably not in Argentina, but it's still in many countries. And many patients don't comply about anything, but when you switch them from efavirenz to another regimen, they just realize how miserable their lives was. Principles that you have to take in account, basically drug resistance. You have to review the antiretroviral history for possible virological failure. Try to align all the available resistant test results. If you really have evidence of prior resistance, consider only a new regimen likely to maintain suppression of resistant virus. You need a strong regimen for that. When you switch from boosted PI to a non-nucleoside class, in particular, resistant or resistant history is not known, you should be aware about that. And eventually, you have to always aim to maintain virological suppression if non-resistant to drugs are present. You have to review the history for intolerance. If in the most uncommon case that you would switch to regimen containing abacavir, which is less frequent nowadays, you must be sure that the HLA is the appropriate one, and you have to take in account drug interactions with co-medications. Also, comorbidities have to be taken into account, particularly HBV co-infection if you are choosing dual therapy based on 3TC, and other issues like renal, cardiovascular, bone, and other co-infections. So, in which situation you should not switch your patient? Switch your patient to monotherapy would be wrong, including dolutegravir monotherapy. It has been shown that this is not a good strategy. Ritonavir boosted atazanavir plus dolutegravir or maraviroc-based dual therapy. So there are two different manners of switching. You can be proactive or reactive. Reactive to that patient that complains that he doesn't tolerate or she doesn't tolerate the current medication, or you could be proactive, just thinking ahead. So you have a patient in the old days, you had a patient on D4T and the patient was doing well. Nevertheless, when tenofovir came across, you decided to switch D4T for tenofovir because you know that in the long run, D4T is a poison. So why would you try to reduce drug burden in antiretroviral therapy? First of all, to reduce antiretroviral exposure, making treatment safer without sacrificing virological control, to reduce the pill burden and improve adherence and quality of life, reduce the risks for drug-drug interactions. Sometimes it's to reduce cost. This is not ever true. Potential for long-term success, since you are sparing some classes for future failure. You have different ways to do so. You can reduce the number of doses a day, the number of pills, the drug dosage, the number of drugs, the number of days on earth, and expanding those in the interval. We will visit some of those issues. First of all, we have a very nice list of STRs, as you can see here, based on non-nucleosides, on integrase inhibitors, and in protease inhibitors, including two drug single tablet regimens, dolutegravir 3TC and dolutegravir rilpivirine, but also in 3 drug regimens, a variety of regimes are available. If you decide to switch a patient to a single tablet regimen based on an integrase inhibitor, you have TAF-FTC and bictegravir, and I show you here 4 studies in which you can see non-inferiority when you compare the results of bictegravir-based regimen to the current regimen, be it in adults, in women, in pediatric and adolescent populations. You can also think about using a relatively new non-nucleoside, which is doravirine, that comes co-formulated with tenofovir and 3TC. In this study, what you can see here is both at the primary endpoint and at the secondary endpoint, there is a non-inferiority shown for the regimen based on doravirine, the non-nucleoside. And then it comes to dual therapy. One of the first studies on switch on dual therapy was based on lopinavir, ritonavir, and 3TC, very similar to the Gardel study that we did in naive patients. And you can see here that for protocol-defined virological failure, any blip or the combination of both, there was no difference in terms of continuing the triple drug regimen or going to dual therapy based on lopinavir. But who uses lopinavir, ritonavir today? Then the same group tested the hypothesis that we did at the Andes study for naive patients here for switching. And again, virological success was shown to be very similar between dual therapy and triple therapy. Look at virological non-response was 3% versus 2%. Adverse events were similar between arms. And then we come to dual therapy based on dolutegravir 3TC. I will show you 2 studies. The Tango study, which is not an Argentinian study, despite the name. It's a study that was done in several countries, but not in Argentina, in which patients that were undetectable on a TAF-based regimen were randomized either to receive dolutegravir 3TC or to continue with the same regimen. And you can see here, and the very important is to show you, the pointer shows. When you look at the switch study, you don't have to look to virological success as less than 50 copies, but to the proportion of patients that lose their undetectable viral load. And as you can see here, 0.3 and 1.3% non-inferiority was shown. For the secondary endpoint, less than 50 copies, numbers are very similar, and the confidence interval crosses 0 here, so there's no difference between those regimes. Important is that patients that had confirmed virological withdrawal were nil for dolutegravir 3TC on only 1 case in the TAF-based regimen, and there was no emergence of resistance at failure. And this looks like a complicated table, but pay attention to the dark colors, which is HIV RNA less than 40 copies with target not detected. That means that your virology cannot detect any type of viral replication, and at different time points, there's no difference between continuing on the TAF-based regimen in orange or the dolutegravir 3TC regimen in blue. Regarding adverse events, it's important to know that any time that you switch a patient that is stable on a regimen, you are exposing your patient to a new compound. So chances are that you will get some adverse events. You can see here 4% of patients that were led to withdrawal in the dolutegravir 3TC arm, 1% in the TAF-based regimen. Low numbers with the difference, obvious paying the toll of exposing your patient to a new drug. The other study is the Salsa study, in which we did participate, even we don't dance salsa that frequently as tango. And you can see here that the patients are different from the Tango study. Patients could be in any type of regimen based on non-nucleosides, integrase inhibitors, or boosted PIs. And they could be on TAF or any other nucleoside. Again, patients were randomized to receive the dolutegravir 3DC or to continue the same regimen. And again, you can see here the primary endpoint, no difference here, no difference in the key secondary endpoint. In the confidence interval crossed the zero, non-inferiority was shown. Again, the same picture, 0 patients with confirmed biological withdrawal, and 0 resistance mutations were observed. And this is very interesting because recently at CROI 2022, a paper was presented by Mike Underwood in which he showed that patients that had history of archival resistance, overall there were no significant differences between continuing in the original regimen or switch to the dolutegravir 3DC. When it comes to precedent of resistance for integrase inhibitor, 100% of the patients achieved less than, continue to achieve less than 40 copies. So it's interesting to see that similar responses with switching to the dolutegravir 3DC and continuing stable heart, the space baseline and archive provide resistance. And look for nucleoside transcriptase inhibitors, in which even in the presence of the M184B, 87% of the patients achieved or maintained virological suppression. Again, when it comes to look at adverse events leading to withdrawal, 2% for the dual therapy and 1% to the continuous antiretroviral therapy. One of the questions for dual therapy was if this would be inferior in terms of changes in inflammatory biomarkers. And as you can see here, there's no major difference, no clear trend. If you look at interleukin 6, soluble CD163, CD14, or serum C PCR. And when it comes to real-life studies, real-world studies, not randomized clinical trials, but cohorts, etc., different cohorts studied switching patients to the dolutegravir 3DC, and as you can see here, the results are around 95%, 99%, 92%, in the worst-case scenario, 83%. So in general, the results are very reassuring that the data that we see in clinical trials are applicable to effectively real life. And there is another combination that is not, at least it's not available in my country, I don't know, here in Brazil, which is dolutegravir rilpivirine. Instead of 3DC, rilpivirine is the accompanying drug here. Again, virological success, 95%, virological non-responses, primary endpoint, 1%. And again, you can see here that non-inferiority was shown. This combination has been approved in the US. In my view, it is more inconvenient than dolutegravir 3DC because rilpivirine has some issues. You cannot use proton pump inhibitors. You have to have a diet that is greasy, with high level of calories, etc. So, and rilpivirine is a non-nucleoside with a low genetic barrier. And then it comes to other way of providing dual therapy, which is injectable dual therapy. And I will show you some data from Atlas 2M, in which patients were started with receiving initially a triple therapy arm, and then they were switched to oral cabotegravir plus rilpivirine. And after 4 weeks, they were randomized to continue every 8 weeks. That means one injection of cabotegravir and 1 injection of rilpivirine every 2 months or every 4 weeks, every month. And as you can see here, the results are very, very encouraging, around 88-85%, and it was very well tolerated, and with a low rate of withdrawal due to injection site reaction, which could be one of the issues. So we are in an era in which we are starting to treat patients every month or every other month. The US guidelines recommend the use of injectable cabotegravir rilpivirine as an optimization strategy for people with HIV on oral antiretroviral therapy with documented viral suppression of at least 3 months. In general, to be on the safe side, I prefer to switch my patient after 6 months being undetectable and having confirmed that they are adherent to the treatment. For this type of simplification or for oral simplification. But the patient has to comply with some characteristic: no basic resistance, no history of prior virological failure, not having hepatitis B infection, do not include pregnant women because we don't have enough data with this type of population, and taking care of drug-drug interactions. Be reminded, for instance, that rilpivirine has a strong interaction with rifampin. So in our countries in which tuberculosis is an issue, we need to be aware about that. Now, after the initial approval for being used every month, in February 2022, the FDA authorized, also approved for every 2 months injections. And one of the issues is, do you need to have a lead-in, an oral lead-in, since it's impossible to chelate cabotegravir and rilpivirine after the injection? Well, you can see here that in this study, the OLE study, as they call it, the patients were studied receiving the injections without oral lead-in or with oral lead-in, and the efficacy results were the same, and discontinuations were really very, very small, and no side effects was present. So that's the reason why some agencies now authorize as optional the use of oral lead-in, and then you can go to direct to inject situation. So in conclusion, I think that the efficacy of our antiretroviral regimen is reaching its ceiling. We have new goals, patient-centered rather than virus-centered strategies. We have 2 types of switch indication, as I told you, reactive and proactive. Bictegravir and darunavir-based STRs are good options for simplification. Some 2-drug antiretroviral regimens are potent, convenient, well-tolerated, and have a high barrier to resistance. And it seems that reverse transcriptase inhibition seems to be crucial by the use of 3TC or eventually rilpivirine. We have long-acting regimens in progress. In red, I underscore the ones we have, oral and intramuscular, but subcutaneous and implantable are coming in the next future. And I think the simplified heart might be the standard of care in the next future. And for my friend Mauro, who is a football fan, I give him this photograph to enjoy. Thank you very much.